start? Yep. All right. Good afternoon, everyone. First, my team and I would like to thank you for coming to our presentation today. My name is Aubrey. This is Lindsay, Jerry, and Glenn. Our interprofessional team is here to present our proposal to provide optimal stroke care within South Tree Health Network. Throughout our presentation, we're going to be referring to this network as just South Tree. The South Tree Health Network in Kentucky is located in the Stroke Belt region of the United States. According to the Kentucky Cabinet of Health and Human Services, stroke is the 5th leading cause of death in the state of Kentucky, and also this state has the 11th highest stroke mortality rate in the nation. Nationally, stroke costs approximately $34 to $53 billion, and out of this amount, Kentucky uses approximately $329 million in direct medical costs. These costs result from a high prevalence of risk factors in the state of Kentucky compared to the national averages. As you can see in the chart here in red, Kentucky has about 1% to 9% increase in each risk factor category compared to the national averages represented in black. And as you can see in the chart, these differences are in fact quite significant. Thus, stroke prevention is a critical aspect of Triple AIM and our proposal. So for our case study, let's meet Lynette Tate. Lynette Tate is a 53-year-old Caucasian female from Eagle Grove, Kentucky. She is also a widowed mother of 3 children and lives alone with her dog, Charlie. Lynette purchased a lower cost option for health insurance only to meet with the ACA requirements. However, she did not take advantages of these benefits due to the large expense of them and her misconstrued perception of being on a government program. Lynette suffered a left hemispheric ischemic stroke. She also has new diagnoses related to diabetes and dysphagia. Lynette faces new difficulties to a decline in performance of everyday functions. For example, functional mobility is impaired. Lynette has a high fall risk, and so she often trips on the loose floorboards in the floor of her home. She's also abandoned the use of her walker because she consistently gets stuck in small spaces, and so she just hangs onto the furniture and the walls in order to move throughout her home. She also has a difficulty in home health and medication management. Despite being educated by the registered nurse, Lynette feels anxious and has difficulty in managing her insulin pen. So she just uses the simplest setting on the pen because that's what she just best understands, despite whether she gets the correct amount of insulin or not. She is unable to drive, and so Lynette has had no access to fresh fruits or vegetables since her discharge home 2 weeks ago. Because of this lack of community mobility, she has been reliant on the pre-made, starchy convenience foods that her children have been bringing her. Her occupation, the care of pets, has also been affected because due to the decline in her functional mobility, she is unable to walk Charlie. And during the course of pet care, she has experienced a fall. The functional decline in these occupations have all affected her ability to also participate in leisure activities. These daily function deficits has led to a loss of roles as a worker, a homemaker, and a mother. This matters because roles give a person a sense of identity and value, and the loss of these roles actually put someone in a risk for depression. Currently, Lynette is on medical leave from work, and she is currently frustrated and overwhelmed by her situation, both physically and financially. However, we must remember that Lynette Tate is a case example of what many people experience in Kentucky. And by examining her case, this can lead to improvements in preventative and stroke care for everyone within South Tree. Now I will hand things over to Lindsay.
Thank you. All right, so as an interdisciplinary team, we have constructed a root cause analysis to determine the process improvement on an individual and community level. In order to find the root cause of a case like Lynette's, we need to start with individual barriers that led to and contributed to the ultimate outcome of her care and well-being. This diagram represents issues identified in this specific case. Ultimately, Lynette ended up with pneumonia, deteriorated mental and emotional health, and the lack of or underskilled self-care. We identified errors in process in 4 specific areas. So, finance, interprofessional communication, coordination, and education. Financial aspects contribute to the limited access to care, limited healthcare coverage, which also incorporates the lack of dental insurance. Decreased interprofessional communication, such as inadequate collaboration and documentation, lack of healthcare screenings, and an electronic health record system differences has led to the outcomes for Lynette. This is further complicated by the lack of coordination, where there's insufficient discharge plan due to the lack of a home evaluation, limited home health option, and a lack of self-care assessment. In addition, patient education was a significant barrier in relation to government programs, stroke warning signs, the importance of preventative visits, and comorbidities, and also, most importantly, the care that Lynette needed. To achieve the triple aim, we will, by improving patient experience, improved health, and a reduced cost of healthcare, we have constructed an optimal care plan. In the financial section, improving access to care by utilizing the government programs provided and also identifying early risk factors will benefit Lynette greatly. Setting up a bundled payment arrangement is our goal for the healthcare settings in the long run. We encourage individuals to utilize dental insurance because we know that there is a significant lack of awareness when it comes to oral health. We also know that periodontal disease has several of the same risk factors of stroke and cardiovascular disease. So utilizing these dental professionals to refer to other healthcare professionals is vital. Improved interprofessional communication is also vital to increase the collaboration and practicing at the top of the license to provide care to the entire body instead of just focusing on one aspect. For example, dental professionals, instead of focusing on just the mouth, can refer patients to the proper healthcare professionals for things that they notice, such as diabetes and high blood pressure. South Tree already has resources available through higher education institutions such as Ginkgo Community Technical College, Eastern Kentucky University, and the University of Kentucky. Through these programs, we will initiate student service learning opportunities to provide free healthcare screenings to the community. And of course, having an EHR system and documentation policies within each practice is a must. Improved coordination, such as incorporating occupational therapy home evaluations and a patient-centered care model, will lead to improved care for Lynette. In addition, we would implement the Target Stroke campaign, which uses the door-to-needle within 60 minutes. In hospital settings, this has been very effective in reducing the severity of stroke, which in turn reduces the cost of overall stroke care. Overall, education is essential in all healthcare plans. Education on the benefits of governmental programs will help decrease the stigma that's within that community. Also, with increased outreach in schools and organizations, we would like to provide education on the warning signs of stroke using the FAST acronym, which stands for facial drooping, arm weakness, speech difficulty, and time to call 911. Our program would implement a higher standard for the time spent educating our patients on their care, condition needed, or their condition, care needed, and compounding comorbidities such as periodontal disease, high blood pressure, diabetes, anything like that. In order to satisfy the triple aim, we will implement a theory known as the collective impact, which Jerry will address next.
Perfect, thank you, Lindsay. So as Lindsay mentioned, our plan to address stroke prevalence in southeastern Kentucky region will focus on the triple aim. To achieve these measures, specifically for stroke, we have devised a plan that will accomplish 3 main goals. First, our plan will reduce the risk factors that contribute to stroke. By addressing risk factors, we aim to prevent stroke within our target population. Next, Our plan will reduce the time it takes to receive treatment after stroke occurs. As Lindsay mentioned, rapid treatment leads to improved recovery in many cases. Finally, our plan will improve care and rehabilitation after the event of stroke. Lynette is an example of someone who struggled tremendously after her sentinel event. We believe that a great deal of her suffering could have been avoided. The plan we present here today will elevate the patient experience through quality, coordinated care. So how will we accomplish these measures? We have 3 major recommendations that South Tree should employ to impact stroke prevalence and care in southeastern Kentucky. These recommendations include a systematic social shift in the ownership and responsibility of community health, a patient-centered, team-based clinical care model, and a targeted intentional stroke program. Please allow me to explain these recommendations in a little more depth. So the most extensive feature of our recommendation is to create systematic change on the societal level by shifting the responsibility of stroke and health management away from the sole enterprise of our public and clinical health institutions, and instead positioning that ownership on a variety of cross-sector institutions within the community. To do so, we recommend that South Tree facilitate a community-wide collective impact initiative. Collective impact occurs when a group of organizations from different backgrounds come together under a common agenda and goal to effect change around a complex social issue. Under the current system, many organizations already provide stroke prevention and care services. However, their efforts and resources are not coordinated, and inter-organization communication is limited, resulting in the potential for duplication of services. What we envision for South Tree and southeastern Kentucky is a system of aligned efforts and resources among the different community organizations. An example of how this can be demonstrated is a partnership between the health district, the public school system, and the higher education institutions. In this situation, the health district can provide educational programming for children that focuses on healthy lifestyles to prevent stroke and teaches how to identify the warning signs of stroke. Additionally, students from local universities can gain service learning opportunities by administering these programs. In this way, existing resources are being utilized, college students are gaining valuable experience, and children are learning lifelong personal health skills and stroke awareness. So our next recommendation is to implement a patient-centered team care model within clinical health service settings. The purpose of this model is to disperse care through a coordinated team of interprofessional providers. This model will place special emphasis on mid-level and therapy care providers in an effort to help lower costs. This will require providers to practice at the top of their license and refer to physician expertise when necessary. To assist coordination of the care team, we recommend utilization of a common electronic health record. Currently, most providers within South Tree operate on the same EHR. We recommend all providers within the network take on the cost of implementing a new EHR for those few providers still on different systems. The shared cost can be justified by the cost-saving potential of a fully integrated EHR. Additionally, the patient-centered clinical care team model should utilize bundled payment arrangements. Bundled payments have the advantage of providing a specified quantity of care given a particular disease episode. One issue in Lynette's case was the inadequate home care visits she received due to insufficient compensation for her providers. A bundled payment scheme would eliminate this barrier. We recommend a 3-year path to risk plan that utilizes fee-for-service arrangements until the network grows large enough to assume the risk of bundled payments, which is our ultimate goal for the network. So our final recommendation is a coordinated stroke program. The important takeaway from this program is an emphasis on prevention. We want to identify high-risk patients before stroke occurs and funnel them to the appropriate educational and specialty services. However, we know that stroke will still occur for some patients. So we have also devised an intervention program designed to utilize evidence-based medicine and funnel patients back to our prevention program to reduce the risk of subsequent stroke. And now we'll have Glenn discuss some finances for you.
All right, thank you, Jerry. All right, so let's talk about the cost of stroke. As Aubrey already mentioned, the cost of stroke to the United States is between $34 to $53 billion annually. That cost for the state of Kentucky is approximately $329 million. Now, that is in direct cost. That doesn't include the cost of lost wages or lost productivity due to time spent for stroke, due to stroke. In Kentucky, stroke affects approximately 12,000 patients annually, adding up to an annual cost of over $27,000 per stroke patient. Now, this includes emergency room, hospitalization, rehabilitation, as well as post-rehabilitation care. So here's what we're proposing. First and foremost, we are proposing an expansion of the current electronic health record. Now, currently, most of the facilities within South Tree are on the same EHR. The EHR is vital to the patient-centered team care model that we are providing and is essential to make sure that all facilities are linked via EHR to provide optimal patient care. Now, we are proposing for up to 10 clinics be brought in on the current EHR. Now, EHRs are not cheap. They're approximately $25,000 per facility, and that's based on the average size of 2 physicians and 5 clinicians within the practice. We will allow for a total budget allowance of $250,000 for the entire network to bring on everybody into the same EHR. For staffing, we're going to require an additional 5 health informatics technicians to take care of the IT side of the business. This will allow for 1 technician for every 2 of the additional facilities that we bring on board. So with an average salary of $60,000 per technician, plus a $35,000 a year benefits package, which includes insurance, vacation time, and retirement, we'll get that taken care of. Fortunately, at this time, we will not require additional clinical help because we'll be having clinical staff operating at the top of their license and utilizing the current EHR to recognize patients to make sure they get the care that they needed. We will, however, require 1 additional administrative position. This administrator will be responsible for overseeing the entire program internally as well as coordinating with the outside agencies to help prepare against stroke prevention. This person will also manage a preventative services budget of $100,000, which can be used for advertising, it can be used for screenings, or however the administrator deems necessary. The total cost for this additional staff will be approximately $585,000 a year. So let's take a look at the overall costs and benefits of our program. For costs, we have our additional staffing at $585,000. We do not foresee any additional overhead or capital at this time because we are utilizing resources that are already in place and just getting them aligned within the program to identify and help prevent. We have our preventative services budget of $100,000 plus our EHR expansion at $250,000. This adds up to a total of $935,000 per year, and over a 5-year period, you're looking at $4,675,000. That is a significant amount, but it is a drop in the bucket. If we are able to reduce stroke by 10% within 5 years, that will lead to a savings of over $32 million per year annually in the state of Kentucky. So in conclusion, our plan is centered around the triple aim. We recommend utilizing the concept of collective impact to increase education and coordinate efforts within the community. This will help improve the overall health of the people of Kentucky. Secondly, we recommend instituting a patient-centered team model to identify high-risk patients, get them where they need to be, and get them education or into the appropriate specialists. This will improve the experience for the patient, and it will also improve the overall quality of the healthcare in general. We also recommend switching to a bundled payment system. We realize this is not possible initially with the size of South Tree Health Network, but with the goal in mind of switching to that, we'll be able to save money significantly for the patients who desperately need it. That plus a 10% reduction in the overall cost of stroke for patients in general will save the people of Kentucky significantly, reducing the cost of healthcare in general. It is our hope and our plan that we can help people like Lynette Tate before they have a stroke and help along the way. Thank you very much. Questions?
Okay, thank you. Really appreciate the time and effort. I know you all put a lot of work into this, so congratulations for doing that. You got it. You're finished, right? Feels good, huh?
Yes.
Okay, great. So I did have a few questions, and I might just jump around a little bit. I think you spelled out on the EHR solution what you guys want to do. I think I've got that pretty clear in my mind. So about $25,000 per clinic or per site.
Correct.
Total expenditure right out of the gates, $250,000. Is that right?
Yes.
Okay. Okay. I got that pretty clear. Can you jump back to the financial slide? Yes. So the 4.675 million. So I'm assuming you just the 935,000. Let me back up. So that's annually, and you're just extrapolating that over 5 years.
Correct.
Okay.
We're looking at a 5-year plan in total because the general idea is to expand South Tree up to 100,000 people within the network during that time period.
Okay.
So our idea is to do this over a period of time to implement our cost savings.
Okay.
ultimately.
Okay. And again, on the bundle payments, so your plan there was to, I thought I saw you going to roll it out over
So we would be utilizing the fee-for-service within the first 3 years.
3
of the
years.
program because
Yeah.
we only have the 4,000 people
Okay.
within that are utilizing. So we would do that for the 3 years, and then after that, or once we reach 10,000 people, then we would switch to the bundle payment.
Okay.
Comfortable taking on that risk.
Okay. So what was the trigger for the 3-year? You said, I think you used the term 3-year path to risk.
Yes, 3-year path
So
to
how'd
risk.
you get the 3 years?
Well, we're trying to hit 100,000 by 5 years, which was a lofty goal. But we think by 3 years we should be able to at least hit 10,000 patients, which would allow us to take on some of that risk of the bundle payment.
Okay. Okay. Great. Thank you.
I really appreciated your focus on the community pieces and your use of the collective impact. But I have a question about the intervention measures. You've proposed a lot of things that look great. Will there not be any additional costs with moving to that, that 60-minute door-to-needle time and the team-based coordinated care plans and the additional home health that you're talking about? What challenges are we going to have as a system implementing those changes?
I think most of it is going to come to getting all of our providers currently within the network to be practicing at the top of their license, meaning that they are looking at the health of the overall patient and working with their other clinicians in that team effort. So if there's any challenge, it's going to be training our current professionals to incorporate that intercommunication, intercoordination between the different providers and professionals.
It's not going to be an easy process either. It's not going to occur overnight. But just retraining people to understand that all of these different places here, let's get back to it, if I can get to it quickly. Okay, all of these different places are offering stroke prevention measures. Getting those people, having them coordinated with our administrator, whatever the case may be, getting them to utilize and move everything in the same direction. That is going to be a huge challenge because everybody has their own agendas. Everybody has their own politics. But since we are trying to be patient-centered, trying to get everybody to understand that's key.
And with the education, we're hoping to having all these different students from different disciplines working together to get their hours with the screenings and everything, that this basically bolsters the idea of collaborating together and being coordinated in one goal.
And kind of to address more of the financial aspect that you were asking about, so the Target Stroke campaign, the door-to-needle within 60 minutes. So we do realize that TPA, the drug that's used through IV for treatment for stroke, that's optimal care, we do know that that's very expensive. However, if we're able to reduce the severity of the stroke, that eliminates a whole lot of financial aspects and that contribute to the overall cost.
So I'm glad you put the focus on the time to TPA. But could you talk just a little bit about the quality and safety of care in the EMS pre-hospital environment? How are you going to address that? What are you going to change? Do you have any plans worked out for transport to UK and Lexington for patients that need endovascular intervention?
We're hoping that the EHR will help significantly with that. If things are documented and actually documented within the EHR, the physicians who are taking over care after the previous are going to be able to see that. They're going to be able to know what's going on with this patient, and we're hoping that that will improve quality care measures for the patient.
But in the case of stroke, by looking at it at more of the patient-centered and team-based, with the bundled payments will kind of help pick up some of the cost of that. That's why you have the big risk pool to help cover some of those costs. We already know currently that of the 100% of the people who have stroke, 90% of the costs come through 10% of the patients. So by having with our bundled payment plan, with the average cost for stroke care for an average patient is about $15,000 over the course of the first 90 days after a stroke. It's significantly over $35,000 for the same 90 days for that top 10%. So by having a large enough risk pool and having those bundled payments, we charge $16,000 for 90 days of care. That'll kind of help eat up some of those costs and cover it for everybody. So that's the general plan.
And how about following, are you going to have a dedicated database that looks at these stroke patients alone? Is this going to be followed through your EHR, or are you going to have a separate stroke database?
It will be followed directly through the use of the EHR, but through the EHR. Currently, I'm working on a plan with a doctor in my hometown, and what we're doing is we're utilizing his current database to go through and identify risk factors and separate those out. We do put them into a separate database, but it is all contained within the same EHR. It's a very simple process.
So that's what we're hoping everyone. So if everyone is on the same EHR, all clinicians in this area will have access to this database.
No questions. No questions. Are we ready for a wrap up?
Yeah, I don't have.
I don't want to rush you guys off now. You want to hang out for a little while? We're good. Yeah. Implementing that.
So, again, kind of coming from the perspective of what concerns do you guys have, or what challenges do you think we'll face as a network in implementing something as challenging as an EHR across all these hospitals? I think you actually addressed your plan that you'd build in some IT people and you'd shift the cost, but I think some of the cost was being shifted to some of those other facilities to pay for the ones coming on board with sort of assumed savings in the end.
Everybody who's under the umbrella of South Tree Health Network, we can share those costs across the board, because the overall savings and getting everybody on board with this same EHR, being able to communicate interprofessionally and across the board, the overall cost savings is going to be huge. It is not cheap, and it is not easy to implement a new EHR. I just saw it with the physician I'm working with. All he did was change from one server to another, and that complicated issues for 2 weeks there in his office. It's not easy, but it can be done, and it's necessary overall. So
I think just educating the physicians on the benefits of the overall benefits of when this new EHR connection is implemented. I think sometimes they don't see the overall benefit, like the $32 million annually that Kentucky will be saving. Maybe they just don't see that yet. So if we just educate them as well, then everyone will be more inclined to be like, oh, okay, well, all right then. And then they'll hop on.
Any comments about how to deal with the cultural issues there, which are huge, about resistance and lack of trust for the healthcare delivery system?
I think part of that is addressed by our collective impact initiative. So if we get these different organizations, and we kind of just listed some healthcare organizations, but this can really grow wider. This can be different social services such as housing, employment. So if we get this entire community talking about stroke and what we can do to address risk factors, and especially at a younger age, if we start to teach this to children, who can then bring that home. I think that we can, it'll take time, but we can start to change how people perceive stroke and healthcare.
And having not posters about the healthcare, but having the FAST advertisement in places that are common and they're comfortable in, like in the grocery store, in the local library, going into their kids' school to drop them off, all that stuff, that the stigmatization will be lessened or maybe even eradicated because they'll be common to it.
As we all know, changing culture is a difficult uphill climb.
Very, very difficult.
Thank you.
Feedback.
Great. Yes. Overall, I think very good. Again, as I said earlier, really appreciate. It's clear you all put a lot of work into this, and so thank you for doing that. And I enjoyed your presentation. Just on the overall presentation, just some comments there. I thought the flow was very thoughtful and systematic. So when I'm looking at the PowerPoint, it all kind of was pieced together, and it was easy for me to kind of connect the dots. So I appreciate that.
Thank you.
I would discourage you all from using notes because I just tell you, it was clear to me that you all know what you're talking about, and I think this Q&A for me, it's very clear that you have really good command of the topics. So it's kind of like, why do you need them? I'd rather. Yes. Yeah, and it's just it's the old thing about eye contact. So you're looking down, and I'm looking down, or what I mean. It's just you didn't need them. So because you know the topics, and so I would just discourage you from using the notes next time you guys have an opportunity to do something like this. I will say overall the RCA was really complete and thorough. I enjoyed going through that. The optimal care slide that you put up I thought was great. Collective impact, I love the definition of that, and I think the strategies, overall, I think your strategies are very solid, but I did like the strategies you had around collective impact. I really liked how you broke down the financial impact of the strategies. You kind of went through each one, very systematic. It was good, very clear for me to see kind of what we would be getting into, so I appreciate that. And then I thought the conclusions and recommendations was very clear and succinct, so overall, I think very good.
Thank you.
Thank you.
Good presentation, well organized. I like the detail and the breakout of the financial analysis and return on investment. I thought that was well done. A pet peeve of mine about RCAs is that it implies that there's a one root cause. And in this situation, there are multiple root causes. So I think I find that somewhat distracting. And I did find the use of your notes to be distracting to us. And I think you four have a passion about this. You're interested in it. You know the content well, so I don't think you need the notes.
Thank you.
Good job. Very good job.
So I would echo everything they said, and I won't repeat it. I think you guys did a fantastic job. Your slides look great. You clearly spent a lot of time putting them together. This was my favorite part. I loved that you got down to public schools and the Department of Health and reached out to at that level. And we're also very comprehensive in your acute care approach and all the other details too. So I think you did a really great job of covering that. Unless I missed it, and I was just flipping back through, I don't think you covered as well the metrics, sort of how you would collect them and what you would measure. Right. So sort of your outcome measures, I think maybe was a little bit of a gap for your presentation. But I agree with the judges. I think you guys did a great job. So congratulations.
Thank you.
Thank you so much for your time.
Thank you.